My name is Dr. Matthew Regulski. I am the medical director of the Wound Institute of Ocean County here in New Jersey, senior partner, Ocean County Foot and Ankle Surgical Associates at Toms River. I'd like to today discuss with you about a new advanced film forming wound dressing that I think will find a very applicable places that you can use in your wound healing paradigm. I have nothing to disclose, no financial interest to disclose, not being paid to give this lecture, but I just want you to understand the goodness behind this new film forming dressing, a product I think that can really help in difficult, chronic, hard to heal wounds. For today, our learning objectives are simple. We'll talk about the mode of action of this special type of silicone film forming wound dressing, which has multiple volatile compounds in it that can do lots of things to help speed up epithelialization, maintain proper hydration, but allow the transfer of gases and fluids and exudate, especially out of the wound into secondary dressing. Why do we want to use this? When do we use it? How do we use it? And then, of course, some of my personal experiences that I've had. I've been using this for a couple of months now and had some really interesting results that we did want to share. So chronic and hard to treat wounds, as you're aware of, is a tremendously significant, increasing population of people that have this significant ailment. High morbidity and mortality costs. We're looking at diabetic foot ulcers that occur every 1.2 seconds in this country. 3% of the world's population now has a venous leg ulceration, which 93% of them are open longer than a year. We know the significant costs that it is to treat chronic wounds, probably about a $98 billion a year market. And of course, the excessive morbidity and mortality that are associated with these as a diabetic foot ulcer has a 47% mortality rate. And if you add that with peripheral vascular disease, that goes up to about 64%. There's even some reports showing that venous leg ulcerations have a 29 to 30% all-cause mortality, higher than breast cancer. When you think about the morbidity and mortality, but the complexity of treatment and the costs are rising exponentially. So there's got to be things that we need to do better to close these wounds quicker. For the longer they stay open, then the greater risk for infection, hospitalization, amputation, and even death. When we think about our chronic wound patients, and some of them think that they are pariahs. I practice in a county here in Ocean County, which is probably the densest for 65 and older on the eastern seaboard. And these people are very private. They don't want to draw attention to themselves when they have bandages on, when they have problems. They really don't want people to know their business because they live in these tight-knit communities. Everybody's is looking at everybody else and see what's going on. But at the same time, they are very nervous. They're very frightened. The drainage of these wounds can, particularly venous leg ulcers, can have an odor to them. They don't want to go places, go out, go to church because they have these complexities and this problem that is becoming everly increasing. And I think as the population ages, 10,000 people a day turn 65 in this country. We know the rates of diabetes, where we have 35 million diabetics, we have 90 million pre-diabetics. 5 to 10% of those will convert into diabetes. We talk about an existential threat to health. That's going to be diabetes. And 1 out of 7 to 8 people by the year 2030 in the world will be diabetic. It's a scary thought. The thing with obesity rates on the rise, especially 1 out of every 2 adults in this country is obese. 1 out of every 3 kids in this country is obese. Western diet, a lot of smoking, no exercise. We're becoming more of an obese population. And we know that obesity underlies 236 chronic diseases and 13 different cancers. So I think if we could get people just to exercise and eat better, we could get rid of half the chronic disease in the world. But then when you think about people that do develop a foot ulcer or a leg ulcer from venous disease, pressure ulcerations, 1 out of every 4 families in this country, the most developed, technologically advanced country in the world, and we still have these problems. I think when we treat chronic wounds, there's a lot of questions to ask. I try to teach my residents that we just don't talk about looking at the hole in the patient. We need to look at the whole patient. It's a multifactorial problem. You just can't look at a wound and say, I want to put this on. Let me put this on. Let's put this on. It's not, it's much more complex. The wound healing process is very complex. We probably only know 60 to 70% of how we heal, because otherwise we would heal everybody. But that is not the case. And I think that in chronic wounds, as you and I see every day, people get antibiotics after antibiotic after antibiotic. And I dare anybody to show me a randomized controlled trial where oral IV antibiotics heal wounds. I don't think there's anything that's out there that can prove that. Now, are they indicated when you have the acute signs of an infection? You have pus pouring out and bones sticking out, abscesses, lymphangitic streaking, things of that? Absolutely. But I treat thousands and thousands of chronic wounds a year, and I probably have given antibiotics to 5 patients because we try to treat things topical. We disrupt the biofilm. We have to destroy those. Chronic infections, 90% of all bacteria exist in the biofilm form. 80% of all infections, according to the NIH, occur due to biofilm, and 98% of chronic wounds have significant biofilm in them. But that does not mean that they need oral or IV antibiotics, because you can't get the flow rates high enough out of the plasma, especially in oral antibiotics, to get it through a biofilm in the first place without blowing out somebody's kidneys. So we have to think about what we are trying to accomplish here. Look at the whole patient and not look at the hole in the patient. And of course, we see multi-drug resistant bacteria are becoming quite the threat. By the year 2050, the number one cause of death is supposed to be from multi-drug resistant infection. They estimate up to 10 million people a day. Now you think of that, and these patients that come in with chronic wounds, you run an old swab culture, which a culture is really not very good. It shows you or tells you 1 to 30% of what is actually there. Can't measure anaerobes, which we're finding lots of anaerobes. Phenogoldia, Peptonephelus, Aeromonas, Peptostreptococcus. These things that can actually lyse keratinocytes and fibroblasts. So now you run a culture over it, and somebody says, "Oh, well, they got staph or they got Pseudomonas. Let's give them Keflex. Let's give them Pseudomonas." I've had patients that have had in 1 year 8 to 10 different prescriptions for antibiotics. So we have to think about what we are doing and what we are causing by the needless use of antibiotics. Just because you take a swab and it shows some bacteria, there's 10 trillion bacteria on your skin, 100 trillion in your gut. Does that mean that chronic wounds need an oral or an IV antibiotic? Probably not, unless they have those clinical signs of an acute infection. And so I think that is a big question, is why we keep doing antibiotics. Why don't we start treating these biofilms, treating these chronic infections that are going on, and then we can get into more advanced therapies. But I think that a lot of times that good standard of care practices are not followed. Diabetic foot ulcer is not treated the same in Maine as it is in California. It's different in Washington than it is in Florida. When you see, and God forbid, people that have cancer, those treatment regimens are standardized all across the country, not in wound healing, maybe because it's so complex, it's so contextual. At certain times, good things are good. At certain times, those good things can be bad. And I think that is the problem. But one thing is for sure, we have to make sure we follow the basic tenets of wound healing. You know, when you think of these people that come in who have a chronic wound, they need a vascular study. How many diabetic foot ulcer patients have I seen have never had a vascular study? And we know diabetes and vascular disease go hand in hand. 80 to 90% of diabetics will die from heart attack and stroke. How many venous ulcer patients never had a venous reflux study? You have to stop that incompetency in the reflux, where your healing rates are 10%. Recurrence rates within 3 months can be 80% if you're lucky to get that healed. Anybody with chronic wounds needs to have a vascular study. Palpation and pulses don't include or exclude the diagnosis of vascular disease. We need to do these things so that we have better outcomes for patients. We know that a diabetic foot ulcer is the number one reason that diabetics are admitted to the hospital. 84% of all lower extremity non-traumatic amputations are preceded by a foot ulcer. And the more amputation, the greater for mortality rate. Once you have a BKA, it's a 50 to 65% mortality rate in 3 years. AKA is 85%. So we need to do all of these good things that we have been taught to do, unfortunately, which we are not. And that perpetuates then the cost. 93% of venous leg ulcerations are open longer than a year. 7% can be open longer than 5 years. Venous ulcers are very difficult to treat. I'd rather take a DFU any day. But I know because people have to work, they're on their legs all the time, truck drivers, waitresses, people that work in supermarkets where they got to stand all day. How many people can take 6 months off and go home, lay in bed, and put their foot up? And thus those costs perpetuate, especially if we're not doing those good basic tenets and then moving into some of those advanced therapies after that 4-week threshold. If we don't see that 50% wound healing at 4 weeks, then we have to move in to those more advanced thresholds or reevaluate and make a better diagnosis and treatment. And I get it that sometimes with patients that it is also the compliance aspect of these people is the same way, that they have to do what they have been taught to do so that they as well can have better outcomes. I know patients that take off their bandages. They try to cut their own total contact cast off. I've had people that do that. One lady in particular tried to cut off her TCC and took 2 toes with it because she couldn't feel until she started seeing blood come out of it. But she was claustrophobic. You think she could have waited till the morning and then come in and have us change it? People that don't want to control their sugar. They like to eat too many of the bad things. Won't see a dietitian to help control their eating cravings and get a better eating plan for them. Not wearing their offloading devices, wearing their multi-layer compression. I get it. There is a compliance aspect as well that can fuel those costs and elevate those morbidities and mortalities. And the multitude of dressings that are out there, my God. And there's no level 1 evidence for any of these dressings. They're all 510K, which means simply that you don't have to show that you do what you say you do, but you show that you have safety data and you do no harm to the patient. There's no RCTs for these dressings. It's all 510K. Think about the multitude of collagen dressings, of foam dressings, of alginate dressings, of hydrofibers, all these different types of foams and different things that are out there. None of them have level 1 evidence that they can do what they say they do. They're all what they call a 510K. But then when you have to think about all these different dressings, do they conform to the area? Do they hold? Do they grip? Do they move? So are they in total contact with the wound bed to wick fluid away, as in your case of your absorptive dressings, hydrofibers, foams, alginates? They have to be in contact with that wound bed so that they can be able to wick the exudate away, because that exudate itself is very inflammatory. And the longer it sits on the skin, it breaks down the skin, becomes macerated, red, wet, and odor, because it's leaking a lot of protein out of there as well. So when we're thinking about an ideal dressing or something that we can put on the wound that accomplishes a lot of these different types of outcomes, right? Things that are able to be permeable to the fluid, to let the exudate pass through and into a secondary dressing without dehydrating the wound or drying it out. And that's a very interesting thing. We have to maintain proper moisture balance in order to facilitate cell migration. We have to put things on that can destroy biofilm and remove that as probably the greatest nidus for chronic inflammation and tissue breakdown and perpetuation of cellular senescence is what biofilm can do and can engender and cause more problems and break off and travel once it's fully formed. Very fascinating entity that is. And the longer these wounds stay open, then the greater risk for infection, bone infection, abscess. So if we can find an ideal dressing that can accomplish all of these different types of subjects that we need to accomplish in order to help produce a healed wound. And again, it's just not putting something on the wound. Remember, it's a multifactorial problem. We have to address all aspects of what is causing the chronic wound. But specifically, I'm talking about something that can go onto the wound and accomplish the things that we need to do. And that's what we're talking about today, is a kind of the silicone film forming wound dressing. It's not occlusive. It allows fluid to pass through, exudate to pass through, but at the same time, maintaining the proper hydration. It's semi-permeable, allowing gas exchange. Okay. I think that's, people have some misconceptions, as I did when I first started using silicone. I thought that it was going to make this permanent seal over the top. And I would say, whoa, what about all the exudate? What's going to happen? Those things, you're going to get abscess. If you don't allow that fluid to move, it's going to break down tissue, lead to undermining, cause acute infections, have significant problems. But it is quite semi-permeable. It's easy to place because you can use your finger with a glove on it or a Q-tip to apply it. It only takes a little bit. It spreads out very nicely. There's no steroids, alcohols, parabens to it. There's no fragrances in it. So it's very good to use on infants, people with very sensitive skin, women that are breastfeeding, perhaps pregnant women, around hairy areas. You don't have to shave the hair, things of that. And you don't have to use a secondary dressing with this if you don't want to, but we do use secondary dressings in the forms of collagen, absorptive dressings, especially when they're under multi-layer compression or in total contact cast. It's a very inert substance, doesn't have a measurable pH. There's no excess hydrogen ions to it. So it's very compatible with all things that are out there. And this new film forming dressing is indicated for all of the chronic wounds that you and I see every day, as well as acute wounds, especially in burns and post-surgery, and surgical incisions that have dehisced. Once we control all those infections, obviously if there's pus pouring out and we get major problems with that big abscess, obviously we need to treat those problems. Once we get that under control, then we can start moving into that realm. Once we get the infection under control, that we can start utilizing this, because it does have some bacteriostatic properties. Because of the volatile compounds that are in there, it can protect bacteria from invading into that film. But at the same time, we want to make sure that chronic infection biofilm that could be quite fulminant are out of the wound as well. But it does have that bacteriostatic property, preventing microbial invasion, but also chemical irritation. This works great on contact dermatitis, putting it around, especially draining wounds where you get the wet macerated edges, the red edges from the irritation, from the moisture retention. This can help ameliorate that, protecting that stratum corneum, binding that together. Whereas if you use an occlusive dressing like petroleum products, and we know anecdotally that petroleum products do slow down the wound healing cascade. All right, that's in the literature. There's no RCTs on it, but it's anecdotal. So we don't want occlusive dressings because we want that fluid to move from the wound, off that wound bed, and out into your secondary dressing. We want that wound to have that breathability to it, but at the same time, maintain hydration so that we can foster proper cell migration. And thus, with a moist wound bed, can't be soaking wet, obviously, can't be dried out. We know that. We know that since 1958, we don't let wounds dry out. We're 90% water. We have to maintain that. But being a gel is another great aspect for it to be used in these hard to heal places, around joints and around curves and bends and digital areas. You get wounds interdigitally. Works great because it's hard to get dressings into something of that nature. And again, because it's very inert, it has no measurable pH, it doesn't contain any of these steroids, alcohols, parabens, and fragrances. You can use it on very irritated skin, people that are very sensitive, infants, breastfeeding mothers, pregnant people, pregnant women as well. And so again, when that dries on there, it forms this protective layer because it's semi-permeable, allowing that fluid to escape, the exudate to escape, but maintaining the proper moisture balance for this that we need to facilitate cell migration. And it bonds to that stratum corneum layer, to that skin, and kind of holds that layer together so that it can't desquamate apart, and promotes the proper moisture balance so that we can facilitate cell migration. And again, having some of those bacteriostatic capabilities preventing microbial invasion is very interesting because of those volatile compounds that are contained within that silicone. So again, here's a schematic showing how that when we have injury to the skin, when we have deterioration of the epidermal component, things that get soaking wet and macerated all the time. And what do we do with that? We put Vaseline over the top of it, trying to protect it from friction and shearing. Well, this works much better, much differently, because it binds that epidermal tissue and preventing that desquamation, that tearing apart of there, because it's not macerated. It forms a dry film over that top, but still allowing the semi-permeability and fluid exchange for there, but maintaining the proper hydration without macerating that skin and causing that skin to desquamate even more. And I think that's an important thing about this dressing, because it's not occlusive. It has the semi-permeability, allowing fluid exudate to escape and maintaining that proper hydration and exchange of gases as well, preventing bacteria from migrating into the wound, okay? And then itself, as it dries, it's not absorbed by the tissue. It's not absorbed by that granulation tissue that you see. It still forms a very nice semi-permeable film layer, protecting it from contact dermatitis, chemical irritation, bacterial invasion, as well as maintaining the proper hydration to facilitate cell migration. Exudate is a big problem, and we know that it's a big problem. If we don't wick that fluid away in a chronic wound, we know that it's full of proteases. We know that it's full of protein. Fibrinogen feeds bacteria. That fluid, if it stays on the wound bed, will macerate it, irritate it, make it red around there, white, and cause odor. And then you'll say, oh my goodness gracious, I can smell it coming a mile away, that there has to be an infection there. But at the same time, to maintain proper hydration is one of the fundamental elements of the wound healing cascade. We don't want it soaking wet. We don't want people taking a shower, putting toxic soap on it. At the same time, we don't leave it open to air. We've known since 1958, when the first blister studies were done, we don't leave wounds open to air. They dry out. It's like cement. Cells can't migrate across an eschar. They have to try to burrow underneath, and that's not how they migrate. So that this silicone dressing accomplishes a lot of those key points that we need for the wound healing cascade, providing that moist wound environment, maintaining the electrolyte status through there. And again, these essential nutrients that we need for proper cell migration and maintaining the proper moisture balance. I think that when we talk about the permeability of dressings and things of that nature, is that we have to make sure that things aren't occlusive. If we don't get that fluid to move off that wound bed and out into our secondary dressing, we're not going to have significant healing. You know the consequences of doing that. And that's another fine feature, as I've talked about, being the semi-permeability, allowing the exudate to pass through, but maintaining a proper moisture balance, maintaining an epithelial barrier in there to facilitate better cell migration. Okay, kind of like we talk about it as a temporary layer of emergency skin, because it binds that stratum corneum, binds the epidermis, and preventing it from sloughing, from the friction, the shearing, any chemical irritation, bacterial invasion, and fostering proper moisture balance for that epithelialization. And the bacteriostatic capabilities of this are in that it is that prevents that bacteria from moving into the wound. Because of these volatile compounds, it can do those types of things and prevent that from moving into the wound, having a bacteriostatic effect on the common bacteria that you and I do see in there all the time. And that is important because there's tremendous biofilm that's in the wound. We want to make sure we treat that and get out that chronic infection. But this does have a capability to prevent ingrowth of those pathogens into that area. So let's look at a couple things that we did with it. And again, burns are very nice to use for this because they're very sensitive. They have tremendous amount of pain. I've used this probably on about 100 people. I have not seen anybody said it was painful because it's very inert. There's no excess pH ions in there. There's not going to be something that it's going to irritate the skin. You can use this on people that are very, very sensitive, have very sensitive skin. This is great for breastfeeding mothers where the nipples can get cracked from that. This is something you could put on there. That's not toxic to the infant too. So in pregnancy is good to use on these open wounds and on infants themselves. It has multiple features that we can be used, but burns can get quite colonized with bacteria and things. Obviously, if there's any signs of acute infection, we want to treat that first. Okay, always remember that infection we do have to treat when we have those acute signs for it. Mohs surgery is another good example for this, help fostering the proper moisture balance, maintaining hydration status to facilitate proper healing and cell migration. And again, just with this gel, much better than using Neosporin, which is very, very occlusive, is very irritation to the skin that Neosporin and polymyxin B, and those are very sensitizing. This offers the same type of treatment, maintaining proper moisture balance, bacteriostatic, facilitating better cell migration, semi-permeable, not occlusive. Mohs surgery, again, this is on the scalp. And you can see with that bone that is exposed, very hard to heal area, very difficult to put things on. And what's interesting with this is that they did not use secondary dressings. They were just applying this a couple of times a day, and which is a nice thing about this. There's no toxicity from if you put more of it on. You put it on to about the thickness of a nickel, cover your wound bed and your wound edges, and you can apply this a couple of times a day. That's what's nice about it, because all those factors that we talked about previously, being this inert substance, there's no toxicity from it. So you can use it multiple times on these patients. And a very significant progression. You can see that bone that's exposed there. Again, maintaining proper moisture balance, facilitating that cell migration. Mohs surgery, again, on the scalp. We look at squamous cell carcinoma that we have here. And again, very difficult areas to treat. And again, without using secondary dressings, it's pretty amazing. I myself do use secondary dressings because our patients walk on our feet. They don't walk on their head. So that pressure will express fluid that's out. And I've used it in these instances in the lower extremity when I've done squamous cell and basal cell excisions, things that we've used it with collagen, with an absorptive dressing. Because, again, because of that inertness, it doesn't interact with different types of dressings, and it's very easy, very conducive, and assimilates well with secondary dressings. And be able to use that again under wound vacs. We've used it in total contact casting, multi-layer compression bandaging, especially around those wound edges where they get very, very wet and macerated for people. It's very nice to prevent contact dermatitis, especially after radiation too. You'll see different types of people that have radiation ulcerations. We see a lot of them. And at the same time, they do get a lot of that dermatitis in the periphery. This is a great area to be able to use that. Again, hard to heal places, hard to treat places. As you can see close to his eye, you're going to cover his head and his eyes with dressings for that to protect that. But you do have confidence of the bacteriostatic capability of it. At the same time, proper moisture balance, semi-permeable, allowing exchange of gases, inert, not toxic, and be able to facilitate plenty of cell migration to help that proliferation. And diabetic foot ulcers as well. Well, obviously, using it in conjunction with offloading, I like to use a lot of total contact cast, a great feature. 90% healing rate with total contact cast. Why is it only used in 2 to 6% of all cases? Definitely have to have offloaded. Can't look at the whole in the patient, got to look at the whole patient. But at the same time, this does some very good things to help promote proliferative phase by those factors that we've been talking about: semi-permeable, proper moisture balance, bacteriostatic capability, reducing friction and shear, contact dermatitis, chemical irritation as well. Venous disease, venous ulcers can be a pain. As I said, 93% are open longer than a year, 7% are open longer than 5 years. Make sure you get a venous reflux study. We've got to use multi-layer compression bandaging, level 1 evidence for that. But we've got to treat the wound. They're very inflamed. They're very wet. They get macerated, lots of biofilm in them. This is something that addresses those points that you can be able to use to protect your skin. And the same way with burns. Be able to manage that exudate, allowing that to move into your secondary dressing while at the same time maintaining proper hydration, bacteriostatic, inert, semi-permeable, no interactions with other types of dressings for that. Using it over joints, bending areas, difficult to get dressings on. This is an alternative that we can use to perpetuate proper healing formation. Again, how to use it. It comes in tube. You can put on a glove, use it, put it on your finger, squirt it into the wound. You want to cover to about the thickness of a nickel. It takes a few minutes to dry. Secondary dressings that you can use over, it's compatible with just about everything. You don't have to let it be extensively dry completely. I let it sit for a minute or so, then I put my dressings on over the top for that. It can be used several times a day if you have a patient that you think is compliant. I can do that. And then hard to treat places that they can apply this daily, or you can have your home nurse do it. Very simple, very easy to use. And at the same time, always make sure you get the wound edges, go around those wound edges. And I do extend it out a little bit, half a centimeter, maybe a centimeter, depending upon if the patient comes in, they have a very macerated wound, a lot of exudate that is seen, a lot of dermatitis around that area. You can go out farther. Again, it's a non-toxic product, very inert. It's not going to cause you significant toxicity. Make sure you cover that wound, cover those wound edges, extend around the peri-wound tissue as well. It comes in this tube, almost a 0.7 ounce tube that you can treat. Again, it's a gel. Just squirt it on the wound, use your finger, Q-tip, and make sure that you cover to about the thickness of a nickel, the wound and the peri-wound skin as well. And with that, I'm going to say thank you very much for your time. This has been a very interesting product. I hope you avail yourself of it. It can do a lot of things. It hits all those bullet points that we need to address that microenvironment that has been perturbed in our chronic wound. These are our references. And with that, I want to say thank you very much and greatly appreciate your time. This is my email address. If anybody has any questions about it or anything in general, I'd love to discuss. I help out in a residency program. My partner runs it. That I'd be more than happy to talk about anything that you need in the wound healing arena. Thank you and have a good day.